Good morning, everyone. My name is Kathryn Gretsinger, and I'm a senior instructor at the University of British Columbia's School of Journalism, Writing, and Media. I'm a senior faculty advisor to the University President, Santa Ono, and I am a proud alumni member of the University of British Columbia. I'd like to start today's event by acknowledging that UBC's Vancouver Point Grey campus is situated on the traditional, ancestral, and unceded territory of the Musqueam people. I'd also like to acknowledge that you could be joining us from any number of places in this land we know as British Columbia, but well beyond that as well. And I do want to acknowledge the traditional owners and caretakers of those lands that we find ourselves upon. We are, it's no surprise to anyone, living through extraordinary times. And last week, the president of the university made a rare statement to the whole community about the importance of acknowledging this moment that we're living in. He said, recent anti-Black and anti-Asian violence in communities across North America has focused our attention on the deeply rooted racism in Canada and globally, and UBC itself is not immune to racism and injustice. Racism is wrong. Racism is something that is systemic in this country and well beyond, and we all have to do better. And this conversation that we're going to be having today with regard to public health, as we look at these numbers and we find ourselves in the situation that we're in, we're seeing stark evidence of what happens when you have a system that is flawed. And we have some wonderful leaders to help us make good choices and decisions going forward. And I'm very, very thrilled to be here today to work with two of them. On behalf of Alumni UBC, the Faculty of Medicine, and the Faculty of Arts, I'd like to extend a warm welcome to all of you joining us today. We're up around 3,300 people watching us live, and there will be more, I'm sure, joining us after the fact. People are here in the Lower Mainland, they're across British Columbia, across Canada, and also around the world, and we're very, very grateful to have you with us. I'd like to thank those people at Odlum Brown and at Alumni UBC and pillar partners at Manulife, TD, and the BMO Alumni Group, and also UBC MasterCard for their support in putting this webinar series together. Now, I have the pleasure of introducing someone who really requires no introduction in these parts. Dr. Bonnie Henry is British Columbia's Provincial Health Officer and a clinical associate professor at UBC. She has been a trusted public presence throughout the COVID-19 pandemic. She's delivered us daily updates, level-headed leadership, and reassuring comments, helping us to understand what is going on every step of the way. Her expertise has been hard-earned. She's been on the front lines during Ebola, during the SARS epidemic, and her public health messaging really resonates with British Columbians and well beyond our borders, as witnessed in the profile that was published in the New York Times just the other day. She has become a defining character for our times, and her swift and sure response to what's been necessary in public health and in the dissemination of information has really been extraordinary. And I'd like to thank you, Dr. Bonnie Henry, for joining us for this webinar this morning.
Thank you. It's great to be here. And I just want to say that I recognize that I'm talking to you from the traditional and unceded territories of the Lekwungen speaking peoples of the Esquimalt and Songhees First Nation. And I'm very grateful to be able to talk to you from here today.
Thank you. I'd also like to welcome the Dean of the Faculty of Medicine and the Vice President of Health at UBC, Dr. Dermot Kelleher. Welcome, Dr. Kelleher.
Thank you very much. And likewise, I'd like to acknowledge that I'm speaking to you from the traditional unceded territories of the Coast Salish and Tsleil-Waututh people.
This morning, we have a rare opportunity because not only are we going to be taking questions from all of the people who are watching and participating in the webinar, we're also going to have an opportunity to listen in to a conversation between two highly respected medical people who are going to talk to one another about the circumstance that we find ourselves in now. So I'll go through a little bit of almost scaffolding information that I provide to all of you now around how to think about the webinar that we're in together. But then I'm going to step back a little bit and allow the doctors to have a conversation about what's going on. And then we'll come back together to talk more about the situation with COVID-19. For those of you noticing the screen, we are using Slido. We found this to be a really effective way to communicate and include a lot of people's thoughts and ideas into our conversations. So all you need to do, as so many of you have done already, is go to slido.com, insert the code public health, and there you will be in the conversation on Slido. It's very much like a little chat room that you would use on your phone. It looks like a Facebook messaging circumstance. So you can just go there, tap in your question, and then we'll try to get to it as quickly as we can. I do have a few questions that I would like to ask of the two of you. And the first really sets up the conversation that I know Dermot wants to have with you, Bonnie. And that is, how did you think about the way that you would approach, on the one hand, slowing down the spread of COVID-19 and ramping up the spread of trust among British Columbians? How did you manage those two things simultaneously?
Oh, it's funny you ask that, because I don't think I thought about doing that. It really is the work that we do in public health, and you know, the product of the experiences that I and others in public health have been through, that we realized that we needed to do the public health work that we do to keep the virus under control. But part of that, as we learn more about this virus, coronavirus in particular, was making sure that people knew what they needed to do, that we all needed to play our part. And so having that trust and understanding and giving people the information that they needed, so they could take the actions that they needed, so we could all protect ourselves, were sort of the foremost ways we were thinking of it. Yeah.
Dermot Kelleher, what is the question that is burning on your mind that you would like to pose to Dr. Henry as we begin this conversation today about public health and human-to-human interaction?
Well, I would say that public health has always been the poster child for how interdisciplinarity works in medicine, because public health docs have always worked, and the public health system has always worked across a range of disciplines, ranging from engineering to hydrology, ensuring water safety and all of those elements. And now we find ourselves in a world where we're being challenged by viral pathogens and by complexities of their relationships with the human immune system. And yet we still, the basic rules remain the same. But how do we engage with the new tools of molecular biology and science to couple that to the basic tools of public health? And what do we need to do to train and educate the next generation of both physicians and health care workers to be literate and competent and excellent in delivering public health care?
There's a simple question for you to take on, Dr. Henry.
Yeah, you know, I think that's absolutely right. The things that we do in public health are often behind the scenes, and you know, we talk about you know, promote health, prevent illness and injury, protect health, and what we're doing right now is focusing on the protecting health. But a lot of the work that we do is around how do we address the underlying causes of health inequities and ill health and good health, and how do we build on those? And you know, what we call the social determinants of health in many ways. And we're seeing much of this play out with whatever crises we have. We know that people who start off with poorer health are more differentially negatively affected by any crises that we have. And so this crisis, this pandemic, has highlighted that, but so is the other crises that we're dealing with here in BC, and that's our overdose crises. And so those people who are being affected by that are even more affected by the pandemic. So our approach is, as Dr. Kelleher says, you know, we need to make sure that we're talking across all kinds of people and sectors in society, and it's that is the challenge that we have, that we're behind the scenes in the woodwork, as people have said in the past, and when a crisis comes and you're at the forefront, it's those relationships that you have built over time that help you know how to talk to people and who to talk to and how to connect with the different people that help minimize the impact of whatever crises we're dealing with.
Right. Thank you, Dr. Henry. Dr. Kelleher, you made mention of this even before we came on the air this morning about the extraordinary nature of Dr. Henry's ability to communicate. As someone at the medical school who's watching all of this, what have you noticed about her approach that you think should be highlighted here?
Well, I just think if you look at the response to the pandemic in British Columbia and the way that people have heeded the advice of the public health system in BC, I think it's a testament to the power of good communication. And you know, I think people will have seen that Dr. Henry communicates in a way that speaks to people in a very genuine way. I think the words "be kind" I think are so such an expression of what is important in medicine and in health, and to use those words at the time of communicating the message of being calm and being safe, and to do that in a way that reaches people. So we were talking before, Kathryn, and I was talking about the fact that I watched Dr. Henry a couple of weeks ago on a Saturday, talking about the simple numbers and the issues relating to contact and surfaces and all of these things, and the communication was so clear and so precise, I think, and effectively left people with a good understanding of what the issues were. And again, that message of being kind, I think, is absolutely critical in this current pandemic.
Dr. Henry, would you like to talk for a moment about your team? Because you're always trying to bring them to the fore and let people know. And as Dr. Kelleher suggests as well, there's a whole range of people from a number of different disciplines who work together to provide the best guidance. So tell us a bit about your team, and then I am going to step back and allow the two of you to have a conversation.
Yeah, you know, public health is a team sport, and I say this to my colleagues all the time. You're never alone in public health, and we talk to each other all the time. So, you know, starting nationally, I talk with my counterparts across the country. It was daily for a while. We're now down to 3 times a week, but it's so important to support each other. And we go through these challenges, and it's all a little bit different. We have a different pandemic in different parts of the country. But here in BC, we also have a really strong team of people across the province. So it starts off with, you know, our basic public health work that we do, our medical health officers across the province, the BC CDC, our laboratory, public health lab, the people who do the surveillance and the epidemiology and pull all those numbers together. It is incredibly challenging, and the epidemiologists and statisticians, both at the BC CDC, but the ones who pull the numbers together in each of our health authorities as well, it's always challenging. And you know, I come out at the end of the day with a couple of numbers, but it takes hours to pull all that together and to understand what it means and the stories behind those numbers. And we have public health nurses, public health inspectors, or as we call them here in BC, environmental health officers, and they're the people that are out there every day doing the work of immunizing our children, making sure that our restaurants are safe, that our drinking water is safe, that our food is safe. You know, we have a really strong team, but I will say, you know, public health, a lot of the work that we do in prevention is things that take time to manifest. And we are, when we're not at the forefront of a crisis, we can be easily whittled away. It's challenging to spend money on prevention. we've had to fight for resources for many years, and then we have crises that arise, and people recognize the importance of having that underlying public health approach to keeping our populations healthy and safe, and to building up the health of those who are most disadvantaged or suffer from the inequities that we have in our health care. So, those are, I can't say enough about how important it is to have those relationships and those teams and our public health teams across the province. One other thing that I will say is that we also have a very strong First Nations Health Authority that has been an integral part of our response here in British Columbia, and why I think it is, I believe we have a responsibility to ensure that we do everything we can to protect Indigenous peoples, because they have been so disadvantaged in pandemics and for other reasons in the past, and building on the resiliency and the strength that we have with our First Nations leaders. So that's an important part of our team too.
And the community that is built through universities and through academic research. So Dr. Kelleher, maybe you would like to speak to that point and then go ahead and ask questions of Dr. Bonnie Henry.
Okay, thank you. So, I think just to talk about the contribution of research to the evolution of the pandemic, I think it's critically important that that people work together at this time. I think that's really the most fundamental factor, because there are lots of elements, lots of moving parts in this whole story. There's the moving parts of the virus, there's the moving parts of how our immunity responds, there's the moving parts around how people themselves respond in a psychological way, and in terms of social impacts of a pandemic like this, where there are unforeseen social implications that don't necessarily manifest in the initial stages. So it's been important for us at the university that we create a coalition of the willing of people who want to work together and who come together. Particularly, we've developed a clinical research task force in partnership with BC CDC and with PHSA and with the other health authorities and other universities. And within that task force, we've been trying to ensure that the data and the resources are being used in the most efficient way to answer the key questions. And actually, I think if there's one message, again, to just re-emphasize, and I think this works at a national level as well, in addressing big issues around something like this pandemic, which has had huge health and economic and social implications. The more joined up we are, the better. The more we can exchange information and exchange tools and exchange understanding, we are in a much better place if we do that.
And can I say, I absolutely agree. I think one of the strengths we have here is very early on, we pulled together a team to lead those clinical and public health and social research questions, and UBC has been very involved with that, as have a number of other universities in the province and BC CDC, and we've been really, I think we've been able to harness the best minds and the brightest ideas, and are contributing to that, and we're in a really good place because we started that early and are able to contribute both nationally and internationally because of that.
Absolutely, yeah. So I think I've got to ask you a few questions now, Dr. Henry. And I just wanted to just begin with this general question of where public health fits in the whole process of healthcare, because right now it's obviously front and center in healthcare. And as you mentioned, as we look at healthcare at a population level, the social determinants of disease, the preventable causes of disease, understandings of what contributes to susceptibility to a virus like COVID, etc. These all come into play. But just, I guess at this point, and even before the pandemic, I think there's been a bigger shift towards looking at health at a population level in a way that we haven't done before. And perhaps you might just talk about how you see public health as being critical to the health services, because as you say, sometimes it's in the background, and right now it's at the forefront.
Well, it's true, and often there's a confusion between, you know, public health and public health care, which is what we have in Canada, and we're very proud of that. But the care part of it is the one-on-one medicine that is so important and is what keeps us, you know, when we are sick. It's the sick care that we need. But, you know, public health is broader than that, and it's the things that we do in our, the more structured things that we do in society to prevent people from getting sick, to promote wellness, to ensure that we can, you know, make sure that people have what they need to attain health and to protect that on an ongoing basis. So of course the things in public health that most people are familiar with are the fact that we give immunizations and we protect children in particular, but adults as well. And there's immunizations across the board. The fact that we have a whole program that stretches from our community into even into acute care hospitals and tertiary care hospitals, but we're underpinning a lot of the prevention work and the way that we try and approach the work on a population basis. So I always say that, you know, public health, our job is caring for the community, not caring for each individual, although everybody in that community is part of our patient, but our patient really is at that level of the population, the community, the people who we can impact on a broader level.
So do you feel that, you know, we perhaps need to have a new form of dialogue between that acute care setting and the public health world, because you know, as we look at what makes people sick in society, there are very large numbers of elements in there that are preventable and could be prevented by expanding the remit and the scope and the buy-in, I guess, to the concepts of public and population health.
Well, last year I released a report, actually 2 years ago now, I guess, called "Taking the Pulse of the Population," you know, and how are we doing? So we have developed some indicators for population health and public health in British Columbia, and you know, it does show that budgets, which are a measure of how we value, I guess, different services in the health system, have been decreasing in all of our health authorities for public health programs. And that's been a huge challenge. And that showed up in our ability to respond to this crisis, where we needed to have people do that really important work that we do of assessment and case management and contact tracing. And we've had to pull in hundreds of people because we don't have those resources in public health. We don't have the redundancy in our system, because it's of course considered waste when you have redundancy in a public system like this. So yeah, there are many things that we can do. One of the things that we talked about was, you know, focusing on those things that make a difference across the board. So having a public health lens to all of our public policy, for example. You know, some of the things that we've done that have made a big difference have been around no smoking bylaws, and having a provincial level, and reducing having the ability to decrease the number of people who are smoking so that we can actually have a big effect. So those are the types of things that are challenging, because not everybody thinks on that sort of system level. And when you are up against the tyranny of the urgent, which means, you know, very important things like people getting their hip replacements or having the surgeries that they need, and it can be very challenging to focus on the underlying public health things that happen slowly over a large population.
I guess the economic costs of a pandemic like this, actually, if you weigh that against the costs of investment in public health, it's very striking disparity in some ways. But I just would like to maybe just move into just ask you a little bit about the preparedness for the pandemic, because you were involved with H1N1 and other pandemic preparedness processes, and clearly you've had a long history in thinking about issues like the ones that we've come up with here. So we're very fortunate to have you in this position right now. But can you tell us a little bit about how you've thought about pandemics over the years, and how your thinking has evolved and changed, and what are the important lessons for preparing for future pandemics or the second wave, etc.?
You know, it is a challenge, because you know, we talk about the well, I call it the J-shaped curve of neglect. When you have a crisis, everybody says, "Oh my goodness, we need to pay attention to this," and we focus attention on it, and then the things go away. And this has happened. I can talk about, you know, tuberculosis, all of these things that we see, and then it starts to come back again, and we say, "Oh well, you know, how did that happen?" When we think about pandemics, it's the same thing. I think we had a sense of complacency after the H1N1 pandemic in 2009, and there was this sense that, oh well, it wasn't that bad. And you know, we missed the fact that actually it was pretty bad for a period of time, and we had a lot of young people who were affected and who were in hospital and needed respiratory care needed ventilatory care for a longer period of time because this virus attacked their lungs. But then we came out of it, and I found that even like after that, immunization rates for influenza went down. We had this sense that we had this under control, and that we weren't going to be hit with something like this. And you know, I have spent, as you said, quite a few, part of my last 20 years, 30 years in medicine has been doing pandemic preparedness, and for influenza, because we always knew there'd be more influenza. But the type of preparedness and the training that you do and the thinking that we went into what we do for pandemic influenza is the same things that you would need for just about any other crises. And so we take those plans off the shelf and use them, what we have. So, but I have to say, I think even knowing all of that information and the data behind it all, I myself was surprised when this turned out to be our worst case scenario, in a sense, because it's not as infectious as influenza, but much more virulent, and not as virulent as SARS, but much more infectious. And it was just in that really difficult type of transmittable virus. And so all of those things that we needed to do, we took off the shelf in March. And we put them all in place at once, knowing that there was going to be a huge economic impact of it. But, you know, having watched this virus travel to many parts of the world, and we had the advantage of timing here in Canada, and in BC in particular, but you know, putting in place all of the things that we did and watching what was happening and realizing that, you know, if our health system became overwhelmed, like we saw happening in some other parts of the world, it would not only mean that we couldn't care for people with COVID, it would mean that we couldn't care for anybody, and we would have increased deaths and morbidity in our communities from non-COVID related things. So finding that balance was incredibly difficult, and you know, nobody does it exactly right. But we needed to make sure we could protect our healthcare system, because once you lose your health, you can never get that back. You can't bring people back, where the economy is something the world can bring back and our government can bring back. Having said that, you know, we are all very aware of the unintended negative consequences of all of the measures that were put in place. And I think that's where we are now. We need to think about, okay, when we didn't know what was going to happen, we put in place a whole lot of things. Now we know, a lot more. We don't know everything yet, and we talked about immunity. We don't know anything. We're not sure about what immunity is or how long it lasts or what it means. But we know a lot more than we did, and we are continuing to learn. So that's what we have to take with us into the next coming months, into the fall. And whether we're going to have a big second wave, I think we can make a difference in how we're monitoring, how we're doing the public health work to stop and minimize cases in our community, to manage them as effectively and efficiently as we can. And that's the work that we will be continuing to do in public health. And then to change our change up our measures as we need to try and keep our society going and keep things going, and minimizing the impact. So that's going to be our challenge coming for the next few months.
Right. And that's where those communication skills that Dr. Kelleher pointed out earlier are going to really come in handy. We have 250 questions that have come through the Slido format. So if you still want to ask questions or participate in voting for which questions you want to have answered, please go ahead and visit slido.com and tap in the password public health. And we will certainly try to include your questions are the ones that you're concerned about. Doctors, we have one question that is sort of ahead of the rest when it comes to public voting. 120 people want to know, are you concerned about Canada's lack of data on race, ethnicity, and health outcomes, and how that might impact responses that support those who need them most? So touching right on the zone that the two of you were just speaking about. Who would like to go first?
I can start. This is something that we have been obviously concerned about. And when we started to collect our detailed case information around coronavirus, we did not include disaggregated data by race or socioeconomic status, with the one exception, and that is a commitment that we've had in British Columbia for collecting indigeneity indicators and working with the First Nations Health Authority around those data. But we have an ongoing and detailed process to look at the unintended consequences, and we are looking at that by disaggregated, by race, by socioeconomic status, and we just did a survey. Over 360,000 people in BC completed that survey, which also asked about experiences over the last few months and includes those very important disaggregated data. So those are things that are important to us, and we know that that's going to help us a lot in determining how best to titrate our responses going forward and where we need to put the effort.
Right. Dr. Kelleher, did you want to weigh in on that as well? Because I know this is something that concerns you.
Yeah, no, I just would concur with what Dr. Henry has said. I think the data from other jurisdictions would suggest that people from Black, Asian, or other minority groups have got a higher rate of complicated COVID infection. So I think it is important as we look to the future that we are in a position to see how ethnicity has impacted, as well as socioeconomic groupings as a further parameter. So these are all important issues for us to address.
Okay, this is a process question. How do we know what the true infection rate is, early projections of 35 to 70% population, when so many are asymptomatic and or untested?
Yeah, so obviously a question that our testing strategy has evolved, as many people would have heard us talking about over the last few months. And early on, it was really around developing the capacity for a test, and it's a nucleic acid test. So it is still what we use to determine if somebody is shedding virus, if they have the infection rate now. But there was a period of time when we were not able to test everybody, and not everybody needed to be tested. And we needed to focus the testing on where it would do the most good. And so how we will understand how many people in our population have actually truly been affected is when we have an effective serology test that allows us to measure antibodies. And I keep saying that we were going to have one in 2 weeks, and it has been more challenging than we realized. And around the world, we're realizing that the false positive and the false negative rates are still very high for these serology tests. And we don't yet know, if there's a cutoff where you need to have antibodies above a certain level to be actually protected over time. And we don't know if the virus changes quick enough so that even if you have these antibodies, you still might be susceptible to getting reinfected after a period of time, as we see with influenza, for example. There's some data that shows that this virus doesn't change as quickly as influenza. I think that means that shows us that it's likely that protection will last for a period of time, whether it's a year or 2 years, or but at least a period of months. But we've only known this virus for 5 months, so we're still working out all those things. Having said that, yes, it will be when we have a good serology test, and our BC CDC lab is working with our public health labs across the country to make sure that we use one or two that give us accurate results and valid results.
Right. We'll move to a conversation around vaccine in a moment, but Dr. Kelleher, I wonder if you might start us off on this one. A question about the relationships between organizations, both in British Columbia and across Canada, but elsewhere in the world. How freely is information moving to develop these best practices? Do you have a sense of that?
Yeah, I would say that actually, again, as we mentioned before, one of the critical factors in this pandemic has been people come together to exchange information, to exchange knowledge, and also to make the most efficient use of everybody's time, because it is important that if we're working to find solutions to COVID, that we work in a coordinated way. And for example, on the issue of serology that Dr. Henry referred to, there are so many serological tests out there right now, but we do have to find what is the right one and the right one for our population, so that we can get meaningful information, and that involves a lot of people working together. That has been the focus of a group that was brought together by David Naylor at a national level to look at serological responses, and which includes representation from all of the provinces. And that's an example of groups of people getting together, sharing information at a national level that will address a really important question, as Dr. Henry says. How do we know who has been infected? How do we know that a serological test is valid and is giving us a minimum number of false positives and false negatives? And to address that, it needs a national approach. Now, I would say that at an international level, there is quite considerable exchange of information. People are talking to each other, and the response of this province did involve communications with many different countries, and Dr. Henry might want to speak to that a little bit. But getting information, knowledge, experience around how other countries have responded, what has worked, what has not worked, what has worked best. I don't know if you'd like to say a little bit more on that.
Absolutely, and not only the public health response, and I'm in touch with colleagues around the world as part of a WHO group that I've been involved in, and others in BC have been part of those groups as well. But also some of the clinical and trials and things. And we have really key people here in British Columbia who are leading some of the trials that are going on across the world, and Canada's been participating. And there's a number of researchers who are involved in that. But those were all built on those relationships that we've had over years, and so it makes a big difference. And people have come together around this in ways that we haven't seen for quite some time. Once the genome was shared, being able to develop tests to work with each other around the world about which tests are working better, and everything from vaccine development to clinical trials. We've been connected with what's happening around the world.
Right. So this next question that comes from our audience is right on point. The world is working on a vaccine. Once developed, what will a vaccine rollout look like in British Columbia?
Well, I can start with that. This is something we're all looking forward to, and we have a chapter in our pandemic influenza plan that talks about mass immunization, and so that is something that we are working on. So we'll have a way of doing that. A little bit will depend on how many doses are needed, whether it's an injectable or a nasal spray. I know there's vaccine research being done on a variety of different forms of getting the vaccine. The leaders at BC CDC are working on some aspects of it. The other part, though, I think is really important is the ethical framework that we will be using in Canada for how we will be rolling out the vaccine. And we have a National Advisory Committee on Immunization that is their role is to work on how we do immunization programs. And they are, even as we speak, using the data that we know about who is most affected by COVID to come up with a strategy, an ethical framework for how we will deliver immunization and sort of how we might need to sequence it. And some of the key things we're looking at are the modeling that help us understand how to target populations best to get the overall benefit. But we will be looking at things like protecting the healthcare system, of course, looking at people who are most affected by this, which we know are often seniors, and they may not have as strong an immune response depending on how this vaccine works. So how do we use modeling and some of the modelers that we have from UBC, Simon Fraser, BC CDC to put together a strategy to help us do that most effectively.
Right. And what happens if there is no vaccine? I mean, if it takes longer, the world is coming together, there's all kinds of gains being made. But what happens if there is a delay or for some reason a vaccine is not able to be established? As doctors, how are you understanding the implications of that possibility?
Yeah, okay, go ahead, please.
Well, I guess there are two parts to the process. One is the development of a vaccine, and the other is of developing effective therapies for COVID-19. So both arms are in progress at the moment, and there are a very large number of vaccine candidates in trial. I think we would hope that one of them, if not more than one, will work. But at the same time, people are doing clinical trials on drugs that might impede the growth of the virus, which is an important thing, or might equally importantly might impact on some of the complications of the virus, the cytokine storm, that process whereby an infection can cause the body's immune response to cause damage to itself. And clinical trials are in progress using drugs that can block elements of that part of the process. So it's two-pronged. I guess if we don't have a vaccine to prevent infection, we will have to continue, I think, using the approaches that we have used to date, and perhaps in a more sophisticated way, perhaps in a way that involves using more data or using better understandings of the I'm not saying better understanding, but just more systematic and early understanding of how transmission takes place, so that we don't get into the second wave in the same way as the first wave hit us.
Yeah, I absolutely agree. I think, with vaccine and treatment are incredibly important, but we also have to learn to live with this virus and minimize its impact on our communities, on our social structure, on our healthcare system. And that's the phase that we're in now. What are the best things that we can do to allow us to continue to live with this virus?
This is an interesting question. If you had one wish for Canada's healthcare system, what would it be? What would you change about the system to make it better and ready for us?
Wow.
One
I have a whole list in my head of the things that we need to do, but you know, I don't. These are complex problems, and you know, I've said this many times for our overdose crises. There is no single one thing that can solve this problem. There are many things that we need to do to support people, and to support us all in getting through this. Whether it is, you know, re-looking at how we structure our long-term care system, re-looking at, you know, our data. We still do not have a single easy way to pull data together that allows us to all use it in an efficient and effective way. There's, you know, from my perspective, of course, there's been a whittling away of public health resources so that we are always trying to play catch up. So how do we pull that together and make sure that we have a robust, always robust public health system that allows us to take these things on? But yeah, there's no one solution that's going to get us out of this. It's going to be all of us working on it.
Well,
Some people would say money, right? And some people would say more money for public health. And then you can nest all of these things in that, but that's too simple. Is that what you're saying?
Yeah.
But more money might help. But I think one of the things that I would see as being critical is that issue of having a joined up learning health system at a national level. And data alignment is key to that. So having the capacity to look at health data at a national level and in real time, with all of the appropriate ethical and privacy considerations, so that at a national level I would say that decisions can be made more effectively at a national level. But I would also just say that the public health dimension has to come more to the fore, in my view. The majority of conditions that people die from or that contribute to morbidity in our society, many of them are preventable and can be modified by public health measures. So I think having a bigger eye on the population, as well as looking at the management of individual patients, but having a bigger eye on the population and having the capacity to use data effectively at a population level to predict and manage disease, I think would be the critical issue that I would see.
Right. Dr. Henry, how do you hope this pandemic will impact female leaders, scientists, as multiple female leaders such as yourself have showed exceptional leadership?
You know, this is something that has, you know, whether it's by circumstance or by just, you know, who happens to be in leadership positions right now, but it is something very positive, I think, I hope. And I would like to see it inspiring young women in particular and young girls. The fact that you do have a voice and you can be you can be good at science and you can be good at arts and you can be a leader in your field. And I know there's many young people in my life and that I look to for inspiration and have told me that it's meant a lot to them. So these are the, you know, I think it hopefully will broaden our vision of what a good leader and communicator is, and to be more inclusive in that going forward.
I just would like to pause and note that right beside you is a piece of art that someone has made of the model. Behind you, people might be able to see just a smidge of pink behind Dr. Henry. That's an image that someone painted. You've been receiving art There are songs, there are t-shirts, there are posters, there's sidewalk chalk. People are trying to participate in intellectual ways, in science ways, in the arts, culturally, in this broader conversation. As a public health leader, seeing the various interventions that British Columbians and others have had around this, what does that make you think about in terms of the possibilities going forward?
You know, I think it's the message that resonated about the fact that we need to be kind with each other, because that's what's going to get us through this, minimizing the trauma and, you know, minimizing the negative consequences and impacts. And there have been many of those. But if we can be kind to each other, if we cannot make assumptions and just stay calm when people are anxious or angry, and understanding that a lot of that comes from fear, and then do what we need to do to keep each other safe. And those messages really have resonated with people, and that's been very heartening. I think it is what we can do for each other to get through and bring hope.
Has it helped you?
It absolutely helps me. It is a little bit, it's not something I'm used to, so it is sometimes a little, what's the word, embarrassing, challenging, but I'm very grateful that people have taken this to heart, and we see that in how people are helping each other out through this.
Here's a question with 129 responses to it. What response is planned? And you mentioned the report earlier, so I know you're thinking about it. What response is planned in preparation for a second wave in British Columbia? And perhaps Dr. Kelleher, you can address this as well. How can we lessen the anxiety and certainty of reopening the public with this in mind? So Dr. Henry and then Dr. Kelleher.
Sure. You know, and I've been quoted as saying it's inevitable. What I really mean is, you know, we know that every other pandemic that we have been aware of in the last 100 and some years, there's been more than one wave. I don't know how big it's going to be, and I don't know when it's going to come, but it's likely to be in the fall. What I do know is that influenza season and respiratory virus season will come again, and it's going to be more challenging for us to differentiate this disease from all of the other respiratory viruses that we see in the fall. So we need to be ready for that. Excuse me, and how we're getting ready for that is ensuring that we keep the community spread to a minimum, sharing that information with people every day, and that's one of the things we will continue to do, but also making sure we have our public health system ready to manage, to find everybody, to minimize the impact, to find cases quickly and be able to stop that transmission. Right now, we don't have any drug or vaccine that can prevent you from getting sick if you've been exposed. So what we need to do is go back to our basics in public health. And that's why we've been talking so much about those safe physical distances, because we know that protects us. And we know that as soon as you get sick, we can support you to get the care you need, but also find those people who have been exposed and make sure that they get what they need so they can stay home and away from others while they're in their incubation period. So that's what we're going to be focusing on come the fall. And we know that it works. We've seen that we can do this. And that's what we're preparing for going into the fall.
Right. Dr. Kelleher, did you want to comment on that as well?
Yeah, well, I think the last comment is the important one. We know that it works, and that's an important matter for people to take on board as they contemplate re-entry into the workspaces. That the system does work and can work in the future, and effectively we are also forearmed. We are not in that period of uncertainty that we had before. We know that we can do things that can make a difference to the spread of this virus. So I think people have experienced really more anxiety at the concept of going back into the workplace than they perhaps experience in leaving the workplace, particularly at the university level as we're opening up the laboratories. But we're doing it in a very controlled way, in a very systematic way, with safety plans and safety plans that comply with provincial health requirements and work safe requirements. And I believe that if people abide by the rules and regulations, that this should be a really safe process. And if there are issues that emerge, that the public health system here has the capacity to deal with them effectively. So I think people should be reassured at this phase of the process.
Okay. Another one, outside of physical distancing and wearing masks, this is interesting. How can the public play more of a part in public health right now?
Yeah, you know, this is all of our public health, and it's being sensitive about the people that we know are more at risk. So we all have to make our own choices about how we expand our bubble, if we talk about that, how we interact in society right now based on our own risk and those who are closest to us. We know we pass this on to people who are closest to us. People that we live with, people in our families, people that we spend time mostly indoors with. So if you have somebody in your family who's ill, who's going through cancer treatment, you need to be more sensitive. And that's how we as a community protect each other. And we need to be respectful of others. And, you know, if I go into a small grocery store, which I have near my house, I wear a mask because I know I can't keep my distance from others. And it's a way of keeping my droplets in. So those are the things that we can do to support each other as we get moving. And we start getting back into those really important things. I mean, Dr. Kelleher talked about the labs opening up. There's been a whole lot of really important research that has been put on hold for a few months. We need to get that going again. We need to be able to support people to go back into physicians' offices, to go back into their workplace in a safe way. So yeah, it is all us doing our part and washing our hands regularly too.
Don't forget the hand washing. We are rapidly running out of time, and I want to make sure that each of you have a moment to make a closing comment. We are not only with COVID, but also with the protests and the Black Lives Matter movement, and amplified attention on systemic racism and so on, living through an extraordinary time. So I do want each of you to be able to comment as doctors where we're at and closing thoughts going forward. So Dr. Kelleher, and then we'll close with Dr. Henry.
Yeah, so first of all, I would like to thank all of the UBC community and all of the academic community for their contributions to our response to the pandemic. The people have responded in the most extraordinarily positive way. They've engaged in so much planning and participation in the development of different ways of education and different ways of doing research, and that has been a significant contribution, I guess, to how we, as an overall BC community, respond. So I think people's responses have been extraordinary, and I think that should be acknowledged. Second thing I would like to say, of course, is that one of the subjects about this webinar was around what's the future of public health, and I would like to just reiterate the importance of public health and the importance of the health of the population in how we think about healthcare into the future. And lastly, you've raised the issues around ethnicity and race and respect, and I think it's really important that as we look at our responses to the events of the last few weeks, that everybody thinks about what they can do as an individual in that battle against racism, how they can take individual action, how they can listen to the voices of others, and also think about how we as a community can move forward.
Thank you, Dr. Kelleher. And Dr. Henry.
Yeah, you know what? I think this has been an unprecedented, we keep saying that, but an extraordinary time. And I will remind people that, you know, it is not forever, but it is for now, and it is the things that we need to do to support each other. You know, race is a learned concept. It's something we created to try and oppress people who were different than us physically, and it is something we need to combat. It is as virulent as COVID can be to an older person. So we need to be able to take the good in what we've learned from each other over the last few months and remember that we can use that good, that kindness to address all of these issues and build ourselves back in a way that's better. And I do believe we can do that. We still need to do it in a way that protects us and protects those who are most vulnerable. So that means being careful when we demonstrating peacefully, but making sure that we respect people's distance, the safe distance, that we're not in large crowds. But it also reminds us of the importance of what I've been saying all along, that we can get through this together if we stay, if we be kind and be calm and be safe.
Thank you so much for your leadership. Thank you both for your time this morning or this evening if someone's listening elsewhere in the world. It's so appreciated. And I just learned so much listening to the two of you. So thank you for joining us today. Thank you to the people behind the scenes on the team at UBC for putting together this webinar and the webinars that are ongoing throughout this extraordinary time. alumni.ubc.ca/COVID-webinar. You can go there and look at this webinar or any of the others that have been put together. Do follow along with the UBC President's Pandemic Recovery Initiative. There will be updates and information available. And as you know, Dr. Bonnie Henry and her team present information daily so that you can make good choices to be calm and be safe and be kind to one another. So thank you so much for joining us today, and we'll see you next time. And thank you both so much. I appreciate it.
Thank you very much.